from the scientific program part, we have one last talk, which will be followed by vote of thanks and Mangalarti. I request everybody to stay with us till the end, and after which you can sign.
It's a talk which runs into 296 slides. So there is no question of completing it. But I'll tell you about, see, I have been a student, I have been there and I have been here. And now ma'am and me both set papers and correct papers like all the other faculty. So I'll stick to what you need to know. You'll see a lot of overlap between this talk, Gyan's talk, Subbu's talk, Vijay Sai sir's talk, and of course Vijay's talk. So you'll see a lot of overlap there, but I'll skip slides. I'm going to stop in 20 minutes. Ma'am's going to stop in 20 minutes. We have a function after this in the same hall. So, this is for all interventionists and all of you. Remember that you're part of a big team. Sun Tzu is a person who wrote The Art of War. He is a Chinese war general. And he says that if you want to win, victorious warriors win first and then go to war, while defeated warriors go to war first and then seek to win. This is not how it's going to be. This is all the procedures that you need. This is what we are given a set for creating questions on. There is a question bank by CCT, by the RGHS, but this is the kind of, at least what you need to know. I'll go through it really, really fast because much of it has been covered. We'll give you this presentation if you want to read. See, PTMC will be asked to you. PTMC will definitely be asked. CAG, angiography will definitely be asked. PCI will definitely be asked. So when you are asked about this, you will be asked about technique, hardware complications. This is how we set a paper. I'm sure you have seen previous papers. Okay, echo is very vital. My talk will be an amalgam of many talks. So echo is very vital because you're going to get valve. You need to decide. That's what actually Vijay was saying. Is it valve disease? Is it subvalve disease? What is the grade of MR? Each of this is a question. Then you will have to talk about T. Sec. In T, sec is spontaneous echo contrast. You grade sec. Do you know what the classification is called? Anybody? It's called Fatkin's classification. Fatkin's classification for sec. That's basically the amount of sec. Is it in the LA less than LAA? LAA more than LAA? Is it clot forming? Is it free floating clot? So you have a classification called as the Fatkin's classification. It may not be asked to you, but then generally you should know this. Echo can be done in an emergency for PTMC. You should know this. It might come for as a part of pericardiocentesis. That could be asked as a question. And of course, you should see the commissures, etc. What was just alluded, you have got different scores, right? Some of the scores, you all said Wilkins, but there are more scores. Cormiers is there. There's a Nobuyoshi score. It's given in the most books. There's a weighted Wilkins score, which we have devised here. There's an Anwar score. There's a Sotaria score. Many of them may be new to you, but you have to go back and read this presentation for this because it can also give you simultaneously MS and MR. This is one of our own scores from Satyasai. So if you see this, the commonest indication for BMV, they'll ask you is the rheumatic heart disease, MS. It can be done in other things as well. I'll skip through the slides really fast. You've all seen this in the earlier talks. This is called tenting of the septum. Some of this could be shown to you as spotters. So this is tenting. You tent the septum and then you tend to sort of puncture it. What is the view that you use? Commonly, we use the lateral and the AP. Jaydeva also uses RAO view. A lot of EP guys use RAO view, where you use what is called as the Hung's method. You go in this view, in this lateral view, you go exactly between the pigtail and the spine at the back. They'll ask you, why do you need? It could be a very askance kind of question. It's not straight question. Somebody will ask you, why do you need an arterial line in like in PTMC when you're doing a venous procedure, right? So you have to say that it's about the hemodynamics. It's about the correct treatment of the injection, that is of the puncture if you have pigtail in the front, and also for knowing the hemodynamics and severe MR. So a typical like a tracing that is shown to you is this. That is the pre and the post on the left and on the right. You see that the valve is open. One question which could be asked, we usually ask this in DM exams, even in DMD exams, is what is an impasse sign? Impasse sign is when you have the distal balloon which is not expanding first and the proximal expands first. If you see on the left here, right down here, if you see this is how it should open. You have the distal first and then the proximal. But if you have it the opposite. That means this is stuck in subvalve, right? It's not allowing it to open. This is called as an impasse sign. It could be asked to you, but then this is, asked very commonly where you have an end-diastolic gradient, and then you have a loss of that gradient once the valve is open. One typical thing which also, a lot of Jayadeva guys speak about, if your exam is there, they'll definitely expect it. Or if their examiners come elsewhere, Vijay was alluding to this. This is the in the Manjunath sir's classification, and they say anything more than 1A, you have 1 to 6, is it 1 to 5? So when you have that, if it's more than 1B, it is a contraindication, because when you pass your LA wire in, it might dislodge the thrombus and can actually cause a stroke. This is the classical balloon. You could be asked this because we have people, I have one of the texts coming here from Pondicherry. They would have seen this here, or maybe in other hospitals as well. The typical thing which we use is an Inui or an Acura balloon. Remember, Acura is a balloon for balloon pulmonary valvotomy. It's written on that. It's written BPV on that. Inui is the classical balloon. Inui was given by Kanzi Inui. He was a surgeon. A surgeon taught us how to do BMV. There's also a balloon called as the Jomiva balloon. Anyone can tell me what it is? It's Joseph mitral valvotomy. It is given by GJ sir, that is George Joseph sir from CMC Vellore. It's called Jomiva. It's a balloon that they use particularly down south. You can use double balloons as well. That's been used in the past. You can use a commissurectomy. It's like a blade commissurectomy. It's not really like a balloon. It's a blade that can cut through. So this is how it looks like. This is a blade commissurectomy. This one, and this is I'll come to the Jomiva. This is the Jomiva balloon, right? So it's a little different from the Acura that we use. So it's basically his name. It's Joseph mitral valvotomy, Jomiva. Always remember that this is asked to you when you open the waist of the balloon. Is it good that you have cracked open? Not necessarily. All the balloons will open. So you have to see whether it is really, because at some point that waist is going to open, right? Whether it's the adequacy of it, no, it need not be adequate. You have to go in terms of seeing it on echo. You have to go graded. Another thing they ask you is, what do you use for sizing the balloon? It's commonly asked in practicals. So you go by height upon 10 plus 10. All of us know that height of the patient is centimeters upon 10 plus 10. But you can also use what is called as the intercommissural distance, right? Which gives you what is called as EBDA, effective balloon dilatation area. You go from the commissure end to end. Exactly how you do say an aortic or like on a PVPD or an AVPD. So you go commissure to commissure, and you can go 1:1 with that. It leads to less MR. So there are other ways of sizing a balloon. That's what I want to tell you. What has happened here? Classically, one of these traces is shown to you. Anyone? So you have the V wave that's shot up, right? So this is something that you see very commonly in patients who develop severe MR, post-PTMC, post-BMV, whatever you call it in your institutes. PMVs, it's also called as BMV or PTMC. So basically, what has happened is the V wave is shot up. The patient need not be symptomatic immediately because the LA is large in many of these patients. So it's prepared. You may not have a patient going on pulmonary edema immediately, but then some of them do with this kind of wave. So what is a giant V wave is all that is asked to you. V wave is also larger in the LA anyways, but this is a really giant V wave. The second thing that's asked to you outside of PTC, I'm not able to continue all of PTMC. It's difficult. As ma'am said, you'll have to get back to us if you have questions. CAT is asked to you. Now CAT is important because CAT, they'll ask you, what is the indication of doing a cardiac catheterization? What is the technique? What are the complications? What is significant step up? These are all favorites of examiners, okay, whether it's DM, DNB or CCT exams. When do you close the shunts? See, this is a very authoritative paper. It's extremely difficult to go into it. It's a 47-page paper, but all of you should read this paper. This is from Indian. I've given you the actual reference here. So this paper deals, this is like 26 institutes in India. All have got together from AIMS right down to CMC Vellore, GB Pant, us, everybody. Jayadeva, everybody is part of this. So this is the paper which deals about when do you do a cath, when do you close a shunt, when can you not close a shunt. It's a very authoritative paper, good for both DM, DND as well as CCT exams. The important terms, I'm not going to go through this, but you should know all this. What is cardiac output? What is cardiac index? That is when you index it to the BSA. You should know about the vigorous cycle. This is good for understanding hemodynamics. It may not be really asked for you to draw it on a bad day. On a bad paper, I have seen once somebody asked 10 markers of hemodynamics of cath. This came about 6-7 years back. So it's a little unfair for a 10 marker sometimes, but at least you should know that these things exist. This is how it is because it tells you in terms of the ECG and these sounds exactly what happens where. See, hemodynamics is the heart of cardiology. If you don't understand hemodynamics, there's no question of understanding intervention. That's a very far cry. This is called as a right table. It comes as a part of your vigorous cycle, which tells you exactly which pressure is how much. put in short, this is what you should understand. These are the normal findings. I keep asking this, haranguing this in the lab. My students will never forgive me for this. I ask this every day in the lab. So LVEDP should be equal to your LA pressure. Your PADP also comes downstream. RA pressure. It's like one hemodynamic continuum, right? And when anywhere that is broken, you need to think what's happening. When your LVEDP is low, LA pressure is high, you have got mitral stenosis. LA pressure is okay, but your wedge pressure is high. That means something is behind the LA. That means it's a pulmonary venous stenosis or something wrong with the lung. So it's like that, you go back, and you sort of dissect out what is abnormal. What are the normal saturations? They ask you this commonly, anything more than 75% in SVC. SVC up to 75 is okay, but if it's more than that, if it's touching 85, 90 on your resting cath, on your resting non-oxygen cath, something's wrong. That means there's a oxygen step up going on here. So this is the normal chambers. They'll ask you, why is it that IVC has got a higher saturation than SVC? One is, if our brains are functioning well, SVC takes up more oxygen. I hope that's the case here. But in any case, it's also that IVC has got more renal vein, which is got a very high flow. So the renal vein oxygen saturation is high. That's why when it drains into the IVC, your IV saturation is higher. I hope I'm understood. So the thing is, all this is important. The common catheters that you use, they'll show you this Sones, Judkins, Emplats. These have been shown by Subbu already. I'm not going to go into the details of it. Once, I think 2 years back, NIH catheter was asked. Just correct me if I'm wrong, but NIH was asked. It's an older catheter, but then you need to know it. It's there in some institutes. Pigtail catheters will be shown to you. So much of this is just spotters. They'll ask you where it is used. Maybe 1 or 2 lines is enough. It can be done either from a femoral or an antecubital vein. Generally, from the femoral, we go across all of the heart. How can you calculate blood flow? How do you calculate a cardiac output in this? You can either go for at least the names you should know, thermodilution and fix. Fix is very simple. Imagine that you have a train which is going on on a toy train which is going on those rails, and you have marbles dropping. That's how I was taught by Dasar and everybody. So you have one thing going around, and again it comes on and again picks up. That's the flow of thing in the body. How much oxygen it picks up as you give oxygen. That's how you calculate. So at least the names you should know. Fix is what we use commonly. You should complete the whole study in 7 minutes, because that's the only time you can get a steady state concentration. And for whatever reason, if you feel that your patient is desaturating, commonly happens in pediatric cats. If a child is desaturating, you may not be able to do a baseline study. So give full 10 minutes, 15 minutes of oxygen, 10 liters per minute, 15 liters per minute for 10 minutes at least, and then start the entire run. But an oximetry run is done before a pressure cath, always, because once you give contrast, okay, you will have a change in pressures. So you should try to do it as much as you can before you give contrast. End-hole catheters are important. It's something that they'll ask you. End-hole and side-hole catheters. Berman is a side-hole catheter. Berman is a side-hole catheter classically used for injecting into a ventricle, because when you inject through a pressure, like into a chamber, you don't want perforation. So you don't want an end-hole catheter going and hitting your wall. That's why you've got side holes and you've got pressure dissipating kind of thing, typically pigtails, or if you have a Berman catheter. Vis-a-vis, if you compare this with an end hole, for example, a wedge catheter, you need it to be end hole, because once you wedge it, you want something beyond that. That is the LA pressure. So these are all basic principles of cath study, right? I'm not going to go into this. ABG machines need to be, always, if as much as possible, the same when you do pre and post, and you should be able to do it as it is collected. So you should not wait on it, because more than 10 minutes of waiting, your entire sats will change there, right? I'm not going to go into details of this. Normal pressures I have already discussed. As I told you, the LA mean will be the wedge. It should not be too different. LVDP wedge will be a little more, 2 more, because you have to have flow coming in from the left, from the right to the left. And LVEDP is the same as your LA pressure, or a little lower, which is the only condition in cardiology where LVEDP is more than the wedge. Parker, 1 Parker for this. Where do you get LVEDP more than the wedge? Not CCP. Acute AR, acute aortic regurgitation is the only thing, because when that happens, there's so much of AR, it opens up your mitral valve and then starts pushing it back. LVEDP goes more than even the wedge pressure. There's no other condition where the LVEDP is more than the wedge. The wedge has to be more, because blood has to flow this way. It has to flow from from the right side to the left side, right? The only condition in cardiology where EDP is more than the wedge is acute AR. Otherwise, this holds true. This is the actual pressure continuum, the hemodynamic continuum in the heart. PADP is equal to your wedge, is equal to your mean LA pressure, is equal to LVEDP. Don't think this is not cardiology. This is all cardiology. This will be asked to you as you work tomorrow, because when you don't see this in the lab, I get jittery. I tell them, flush the line, something's wrong. And then, there's either a bubble or a clot or something there. So a lot of this matters. This is one of the most loved questions in cardiology. Everybody's going to ask you this: what is a significant step up? When you have a normal flow of blood, there shouldn't be extra oxygen coming in from anywhere. Now, when you have that, it depends on how many samples you're taking. Typically, if you're taking, in most hospitals, we take single samples. We take an SVC, we take an RA, we take an RV, we take this, that, right? So it's single sample. When you have single sample, it's the third column. It's 11, 10, 5, 8. When you have this is what you actually go by. So it's 11 at the level of atrium, 10 at the level of ventricle, great artery level is 5, and when you go SVC to PA, if you take only 2 samples, it's more than 8. So, or if you take multiple samples, if you take an averaging of then it is 7557. Where is that? This one. So this is when you have, if you're taking multiple samples, otherwise it's 11, 10, 5, 8. If you have anything which is, increasing more, for example, what I mean by this is SVC should flow to RA. The same blood. Why are you saturating more in the RA? That means something else is getting added. RA should flow to RV. RA and RV should be the same. Why are you having RV higher? So everything which is there, this is very important, because this tells you where your shunt is. You may not be able to even see it on cath, on like echo. There may be a small shunt. pH may be there. It may not be a very great shunt. So you will need to do this and understand this. They ask this in the exam. So when we see for screening, at one shot, if you have SVC and PA samples, I told you, if it's more than 8, 11, 10, 5, 8, I told you 8. So if you have only 2 samples, SVC and PA more than 8, means there is a need to understand there's a left to right shunt. They'll ask you causes. They very commonly asked, what are the causes of oxygen step up at various levels? AHD at the atrial level, obvious AHD, PAPVC, RSOV, VHD with TR. TR means there's more RV to RE shunt and then coronary fistulas. Ventricular VHD, PDA, PR, ostium primum, because you may have a LV. Sometimes you have an LV to RE shunt. That's also there. It's called as a Gerbody, what Dr. Vijay Sai was telling you. And of course, you have coronary fistula to RV. At the great arterial level, PDA, epivindal outlet, VSDs can cause this, because they tend to go more towards the PA side, and of course the coronary erosion from PA. Can I just ask one question here, to see how many of you are awake still? You were told in the earlier talk that when you have your PSAX view and you have a jet coming from the LPA, right? On this side, it's PDA. I ask you a question. It's coming from the medial side. What is the diagnosis? No, you may or may not get. Epivindal is a very broad shunt. It may go this way. Which same kind of jet you're getting from the medial side. Al-Kappa. Usually Al-Kappa comes from there. That means it's you always remember Al-Kappa as a reversal of that. Of course, you'll have a lot of other things. You'll have septal collaterals. You'll have endomyocardial fibrosis. The myocardial, the pap muscles are scarred. But one thing that comes from the medial side, always never miss it, is Al-Kappa. You have these calculations. If you remember it, good. If you don't, I don't know whether you really need to know it. But sometimes it's part of the, I just put it because it's part of your syllabus. Angioplasty, is it just access via balloon stent? No, it's much more than that. This is you and your team, right? And this is your patient. So they don't know. So when you are jet setting, you are the one who's the pilot. So always remember this. This is not part of CCT course, but this is part of life for you if you're going to be in the cath lab. This is something I have learned. Being in the cath lab. Check your plan, double check your plan always. Plan access as you need. This is all part of it which you can write in exams. If you don't remember anything, just write all of this. Somebody will think that you know. Whether you know or not, that's a different thing. Plan of interventions as per CAG. Think, what is the type of lesion? Is it, how much of myocardium is subtended? What is the catheter? All those discussed by Subbu earlier. Which guide, right? Is it anomalous, non-anomalous? Is it like what type of wire? I know a lot of this may not be for you, but at least know that all these things, existed. They ask you what is POBA, POBA. Anybody? What is POBA? Plain old balloon angioplasty. It's plain optimal balloon angioplasty. It was done. You just go in there, open a balloon, and then come out. The first one was done like this by, Andrea Grunzig. So that lasted 22 years. They didn't need a stent then. In any case, eyes should be on the wire tip. We were just discussing about it in the lunch break. We have had technicians in here and in Puttaparthi who their eyes used to be on the tip of the wire when we were seeing there. It was like, no, you're going to get ectopics. No, sir, it's going out. It's like that. A good tech can teach, as ma'am said, a new doctor. So your eyes have to be on the lesion, on the guide, on the wire. Are you in, out, on the contrast volume? Okay, mindful of radiation. This is your checklist. I think all of you should take this back as whatever little learning that you can take from life is that do you need when you start, don't cry in between the case. Do you need a backup support? Do you need a long sheet? Are you going to have groin issues? Do you have blood? Do you have covered stent? Do you have a calcium? See, there was a question which was asked this year in the last exam, approach to a patient with calcium. Now, how do you expect a CCT student to know all this? But then, that's a requirement today. How long is the left main? Is it short? Is it long? Do you have side hole guides? All this makes a huge difference because you are going to be, in the era of FFR. You start with a guide and then suddenly you pass the wire, everything, and say, oh, it's a 70% lesion, but I have side holes. You can't come out and do the whole thing all over again, or you'll have to do that. I mean, there is no other unless you give IV adenosine. So the point is, planning the whole case is extremely important. You are part of a larger team. Remember this. There's no time to go into all of this. I'll just go through it really, really fast. Guide wires. This was already discussed by Subodh to some extent. You can have flexible tip. Any wire has got 4 parts: the core, the body, the coating, the tip, and of course the coating. And when you go with this, this is they're all very long wires. For our coronary, you can use 180 or 190 wires, or you can use a 300 wires also. So go through this. What is the purpose? Tracking axis and then crossing the lesion and then providing support. I'm not going to go into all of it. They might ask you this: what is talkability? What is steerability? Have you heard about this? To reach a lesion is talkability. To go through a lesion is steerability. To reach there is talkability. So it's like that. And like, can you push? So there's a lot of stuff in this which is part of intervention. What wire you give to your cardiologist will be dependent upon the vessel anatomy, lesion, devices, etc. I'm not going to go into the bit of this. It's part of the talk. You can take it later. I think we'll share it. So the basic point is this: if nothing you understand in this, they'll ask you this coronary wires. Write that it has 4 parts. It's got a core. It's got a body. Right? It's got that's either tip up core to tip, or that is one piece, or if it goes 2 pieces, that is it will go till the end, and then there will be a ribbon, shaping ribbon, and then you will have a coating around it. So this is what it is. It's either stainless steel or nitinol. No, some wires that your institute uses, they'll always ask you this. We don't expect a lot from you on this, but they'll ask you, what does your institute use? Like somebody from NH, they'll ask you, what do you use? It could be different from what somebody in Satyasai uses or somebody in Jadeva uses. Coils, radio tip. I'm just going through it fast. Coating. All of this may or may not be asked to you. How do you classify? This was also discussed by Subbu. So you go with the construction material. At least these, simple points you can write: tip style, tip cover, coating, on if it's tapering or not, if it's flexible or if it is stiff. Then support is there. Support wires are there, and you can actually have some desirable characteristics. I'm not going to go into the tip of it. CTO wires we had discussed. At least you should know that there are some specialty wires which are very high in their tip load at times, and they are very stiff wires. They can perforate, and they're not very safe to use unless it's a expert user. I was discussing this in the morning. This is pseudo lesion or concertina. This is what happens when you have a wire which you put into a tortuous vessel. Typically, he showed you the OM, but it can happen into the RCA very commonly, because when you put in a wire and you straighten out something which is tortuous, then you can have a concertina even on, and then you start thinking, oh, have I dissected? Should I put in a stent there? You could have a small lesion and it looks horrendous. And after you take your wire out, it actually comes back to normal. So how do you deal with this? You put in a microcatheter, take your wire out, and then you inject. All that comes back to your normal thing. So you should know this name. I have asked this many times in the cath lab, and the reason being, I have found that this is asked very commonly even in your practical exams. PTA guide wires are different. Is something that is different. PTA is basically peripheral angioplasty. You might need to go for 035, 032 wires, much stiffer. This again was touched upon in the morning. Diagnostic and interventional guides. Diagnostic guides are tapering. Guides will never taper. Diagnostics are two layer. They don't have the Kevlar. They don't have the stainless steel in between. While your guide catheters are much stiffer, and they have a Kevlar, they have a stainless steel braiding, and that makes for more support. So support as well as conduit. It's also a vehicle for contrast injection. You can measure pressure with that. You can change the shape as well. Earlier, we used to have these dry blowers, which you use for hair drying. We used to actually take it in the lab and used to blow dry and then change the shape. It's not done these days because you get better catheters. The parts are of course there. I'll leave you with this. This is how it looks like, the inner liner, and you have the Kevlar in between, the stainless steel and the outer jacket. Please read this when you can. Guide sidewall versus no sidewall. Always remember that you'll see your cardiologist doing this very often. Oh, I am damping in the RC, I'll put a sidewall. Then there is no damping. You're happy. Nothing to be done. It's just showing you aortic pressure. It's not showing you the real pressure. Am I overshooting, ma'am? Am I overshooting? I'll just go faster. Most commonly used guides are these: the Judkins guide, Amplat's guide. Also, Subbu told you it's a very aggressive guide. Don't we don't use this unless our usual EBOs or your Vodas the extra backups don't work. And of course, we can use it for the anomalous RCS. Multis can be used. Long tip catheters also used. Extra backup guides are used. You're not going to be asked about all this, but at least you should know that these exist. Right. After coronaries, I have a couple of things which are important for you. This is all was heard in the morning. Tiger, Jackie. I think a lot of it is repetition. We try to combine our talks actually, both of us, because we knew it was going to take a long time. Balloons will be asked about. This is something that you have been asked. This is you can have different types of balloons, compliant, non-compliant. You should know about scoring and cutting balloons. They are used for calcium. Basically, they have a wire around it. Or the cutting balloons have got atherotomes. They have got blades which cut through the lesion. They're used for calcific lesions. Okay, and for resistant plaques. Yeah. Stents was also discussed in the morning. So the same thing what he had shown you, different types of stents, different generations. One more thing is covered stents might be shown to you. These are stents which are used for perforations typically. So in the valves we have got like valvotomy, like pulmonary the balloon valvotomy for the pulmonary valve, pulmonic stenosis. Classically, it is done when you have a gradient of more than 60 or 40 mean, so 60 peak to peak.
For third years, these are all full questions. Pulmonary valves, AVBD, PVBD, they're all full questions. So please pay attention.
So when you decide, the decision to make a pulmonary valvotomy or not in the cath lab is done by you and us, because when you see an echo, that's where it starts. So when you see a pulmonary valve, you see the doming in the pulmonary valve. Classically, in PSAC's view, you see the post-stenotic dilatation. That tells you that the valve is amenable. Because when you do not have either, if you have a nubble of a tissue there and you do not have post-stenotic dilatation, that means that the valve is dysplastic, right? If it's doming, typically with the post-stenotic dilatation, then you are happy, you get a good gradient. This is the valve that's going to be really helpful. Also, you see in the PSAC's view whether you have an infantibular gradient. So when you have an infantibular plus valvular, sometimes it's actually helpful because when you crack open the valve, your infundibulum will not allow you to, not allow the development of pulmonary edema, sudden flow of blood. But then if it's purely infundibular less valvular, then valve is not going to be helped by opening. That's something that you need to know. So I'll just show you how it's done. How do you choose the balloon size? You choose the balloon size based on the valve size, on the valve diameter, which you take as a lateral view. You can go from up to 140%, 120 to 140% of the balloon to the annulus ratio. That means if your diameter was 14, you can start with 14, you can start with 13, 14, whatever is available. You can go 15, you can go 16, up to 120 to 140%. Up to. It does not mean you have to go. You have to choose your balloon in a sort of a graded manner. When it's aortic, vis-a-vis aortic, aortic cannot be going more than 100%. You should never cross the diameter in an aortic against a pulmonary where you can go up to 120 to 140. That's called as the balloon annulus ratio. Somebody might ask you this, what is the bar that you used? So you can use a single balloon or a double balloon. I'll just come to the main ones. This is how it's classically done. First, you would see the balloon, see the valve size, the valve annulus, then go across it, take a JR catheter, go across it, see the PA pressure, and then you have to dilate. As you dilate, you see that the valve is cracked open. Here we have used a 1:1, and you see that the center one is clearly opening after the dilatation is done. And you should take the pre and post pressures. It is classically done with an Acura balloon. With a Tyshak balloon. A Tyshak is actually Ty and Shaq. It's actually it's sort of connected. David Tyrone and Shakil Qureshi. They were the ones who actually manufactured that balloon. It's called Tyshak. Most of you must have heard that. That's a classical balloon used. But you can also use Acura. Acura can be used if there is a large annulus. Acura is a balloon. Acura is a thing that we use for mitral valvotomy. But it's actually a balloon which is meant for large annulus pulmonary valvotomy also. If you do not have an IVC entry, what do? You can do a jugular PVBD. These things exist. At least you should know it. Okay, supposing my IVC is interrupted, what should I do? Like middle of the case, you found out that you've already taken a puncture. You don't have to disband the case. You can come on the top and you can actually go around. This was done also in our hospital. So techniques are these: single balloon or double balloon. There's something called a suicide right ventricle. You might be asked this when you do a pulmonary valvotomy. The RV can go into contractility. The infundibulum can go into contractility. It can actually cause hypotension. Okay. Then comes the aortic valvotomy. Aortic valvotomy is done in two ways: retrograde or antegrade. I'll come to the cases directly. The retrograde is essentially when you would go across the valve retrogradely and then dilate it. Typically, you would be asked what is the balloon size. So it's 1:1 max. You will be asked why is TPI put, because you want to rapid pace and the balloon should not bob. And after doing it, you have to measure up AR. If you cannot go into the LV retrogradely, you might need to go antegrade. Now this is nice. You go from RA to LA, go back, snare the wire, right? You come back around this and then take the balloon down. So that might need a septostomy, an atrial septostomy. Also, you could be asked about, this was asked last year. This is something I added yesterday. This was asked to you in last year. What is alcohol septal ablation and what is the indication? What is the complication? Something was asked last year about PTSMA. So this is something you need to know. It's basically a knocking out of a septal which supplies a large septal which will supply the upper part of the septum, which leads to the gradient in HOCM. So these are the steps in it. We have passed the wire and then occluded with a balloon so that there is no reflux of alcohol. We give alcohol 99%, kill the septal and necrose it off. This is something which is asked to you commonly. Device closures can be asked for ASD, VSD, PDA. I'll go into absolute basics of this. How do you pass? All this was actually discussed by Dr. Vijay Sai. So you would want to pass the wire across. I'll just show the cases, ma'am, directly. Right. So you would want to pass the wire across and then you can do something called as a stop flow method. That is, you can use a balloon sizing. It's not used anymore. And after that, it's actually deployed in an LA-RA fashion. That is, your disc in the LA side will open first as shown here. Then you pull back, you feel the septal resistance, and then you open the RA side. It can be done also on the jugular axis. You can do double ASD. This is also done in this hospital where you have done LA-RA. LA1, LA2, RA1, RA2. That is, you can put double devices.
You all have been in the cath lab, no? Everybody. How many of you have seen ASD device closures?
How many of you have seen ASD devices being deployed?
Yes, very good. Somebody has seen. So this is a full question for you. Unfortunately,
I'll need one day for this talk.
We actually have given this course as an introducer course. But please go back and read. All these are full questions for you individually. It's not possible to cover 1 year's portion in one day, obviously, right? So that's why this topic is we are rushing through this. But get the headings. Please get the headings and go back and read, okay?
VSDs can be seen first. We will inject a VSD first and then we can go either retrograde or antegrade with or without a loop. So this is actually VSD closure. PDA closures will be asked to you. This is also asked as a 5-mark question. So at least they'll ask you what is the classification of PDA. It's called as the Krichenko classification. Okay, for those who don't know it, it is basically conical window tubular complex and elongated. And we'll need to plan this out either as a coil if it's less than 3 millimeters up to 3 millimeters, as a device if it's more than that. Then under 1500 grams is something which is done in South. I just put it because you should know this. There's a device called Piccolo, which is done in infants. Have you heard? They'll ask you. They'll not ask you what is the deployment and all. So it's done seeing either the LAO or the RAO views. PDA also, if I could just add on to the question, have you people seen PDA device closures? So this is part of that. Okay, you take in either a lateral or an RAO view and then plan up that. A few last slides. COVID dilatation. COVID can be done in the cath lab for people for children with a gradient of more than 20 is an indication actually. But if its LV is down, then even that gradient may not be reached. You should know all this. One thing about what Vijay's talk, which I wanted to add on, was when he discussed MR. See, MR is a very dynamic thing. It can change the pressure of the patient. Some patient's pressure is 200. His MR will be too much. You get the pressure down to 140, like his MR will actually decrease on echo. It's not that anybody is wrong or right. Your colleague would have seen severe MR, you are seeing less MR. It can be dynamic. So these things can change. That's why, all this is measured up against LV pressure. So it can be done as as a coa balloon dilatation, which is shown here. And it can be done for recoase. Patient had a stent and again you put it in.
COA full form.
COA is again a full question. COA is again a full question, a simple COA, complex COA, or whatever. So I know it was a rush through. Will give you the slides, but then this is most of the things. What I have not covered, I'll actually put it today morning. We have not covered peripheral angioplasty, right? We have not covered in the entire session. I mean to say, even Anand couldn't cover about ICD, CRTs. I think you should go back and read that. PCI complications, Subbu had alluded to this, but then slow flow, no reflow, along with perforation dissection. Pay attention to the to all the hemodynamics, because we are not going to hopefully see you next year sitting here. I'm sure all of you will pass out. I mean, we don't want anybody to come back here and sit, at least the third year students. So read about the hardware. This is what the questions are framed with. It's about technique, complications of all procedures which I mentioned, and amalgamate your answers, right? If you do not know, think about it, close your eyes, think what you've seen in echo, what you've seen. When we see a composite answer, sometimes you actually get more marks. Attempt everything, do not leave questions, but expect nothing from the examiners, like me, for example. Thank you.
See, thank you all. Just we are winding up. We'll have a vote of thanks and Aarti. Don't go. Please start observing more. Don't think that all of us were taught all of this in one day or 1 year. Okay, whatever we have learned over several years. And I tell my students, even the CCT students and the DNB students, please observe. Nobody will give you a eco probe in your hand and say, okay, start. Please don't expect that from your seniors. So don't feel your seniors are not teaching you, are not allowing you to do, because you're all still students, right? The first thing you should do is start observing. How is the probe held? How is that person holding the probe? What view is he getting? What is he doing? So start from there. And whenever you come to cath lab, also please observe what's happening. You may not be handling the table directly because you're still students, but observe how is it being moved, what is being seen, whatever is being done. It is your astute observation which will lead you to you becoming better and better by every day. You don't expect that once I pass I'm going to know everything, unless you start observing today. You have to start observing what your seniors, your teachers, your staff are doing, how they are doing it, why they are doing it, and then you have to go back and read. That's the only way to make yourself complete as CCT technicians. Will can you quickly wind up?
Thank you so much, sir. It was really a very concise.
Minute. You have 1 minute because
Thank
there's a
you.
team waiting out.
Yes. I think it's very important to have a feedback loop where you're constantly thinking about how you could be doing it better with inputs from various quarters. So I would like to invite the audience for their inputs. Anyone from the audience could please give their inputs for the session. Thank you.
Yeah, my my name is Prem Kumar. I have some doubts. Okay. AV nodal block will how made block, ma'am? AV nodal block happens means what is the reason for the block? Like that the disturbances in electric.
There are certain genetic predispositions, and certain children are born with a congenital AV block. That will be a complete heart block. Nobody is born with a Venke back or all those things. Okay, if at all they are born with a block, it will be a congenital complete AV block. The other thing is that it could be an acquired condition. So it could also be post-operative. People go in for a VSD surgery, they go in for a TOF surgery, and they get a block because the surgeon has to bite through the tissue very close to the node. So that could be acquired as post-operative. It could be acquired as degenerative. You've seen aortic stenosis in the older people. You have a lot of how does aortic stenosis happen? Fibrosis, then calcium. That calcium, that fibrosis can go down into the muscle, into the tissue, and affect the node. So people with severe AS can have CHB. or they can start with LBBB or RBB and then go on to get CHB. Any degenerative process where severe fibrosis happens in the muscle in that ventricular septum perimembranous area can lead to a complete AV block.
And also spoke about ischemic. That was also discussed.
Yeah, ischemic is where the vascular supply to that particular territory that is usually transient. It recovers, but permanently these will be the causes.
Rarely.
Yes, it can happen. In the last stages, it can happen. If there is extreme dyselectrolytemia, it can happen. You have to correct the electrolytes. Yes. Yes, it recovers. Yes, it recovers.
And that is a very beautiful thing about ischemic heart block, which you will not get to see.
You don't get to see this. Somebody has an ischemic heart block, ischemic CHP. You get to see the CHP, right? You don't get to see the progression. But the beautiful part is it regresses as third, second, and then first, and then normal conduction. You could not see the progression because the patient came with CHP. It maybe happened when he had the MI, when he was being transferred. But the regression of it is always 3, 2, 1, and then normal. That's why they always say 14 days after an MI, if there's a CHP, you have to wait. You have to put a TPI for 14 days, either from the groin or from the neck. Wait on it. Do your revascularization. Wait on it. 14 days later, it doesn't revert. Then you may need to put. The same thing is followed even in post-cabbage. They'll wait. So those are, as ma'am said, transient ones. But then if there's an ischemia and infarction of that node, infarction, that will not recover. That will become slow, wide, not narrow complex. That mandates a surgery. I mean, this thing, TPI. How? Can it?
Okay. How?
There is something. For this, you need to go back and learn the phase 4 depolarization. That's not a part of this. I think you need to go back and learn that. Phase 0, phase 1, phase 2, phase 3, and phase 4. Phase 4 is flat in fibers which do not generate any, excuse me. Phase 4 is flat in cells which do not generate it, like ventricular cells. But when you have an SA node, when it comes down to phase 3 and phase 4, it starts going on a slope. Once it goes on a slope, it fires. And that happens every beat. If it is not happening, then that is from the non-pacemaker cells. That's why when you have pacemakers, how many pacemakers do you have in the heart?
See, so
How many pacemakers do you have in the heart?
1 minute, Prayaag. I'm telling
Millions. Remember that, it's not one.
Prayaag was coming to that point.
Correct.
All of you were asked for feedback. He picked up the mic. So he gets to talk. Right? He's the SA node. He was just faster than everybody else to pick up the mic. Simple.
But he could go in AF if you ask him to speak more.
So if he did not pick up the mic, somebody else would have picked up the mic. So one pacemaker does not work, something else will take over. So that's how God has given us so many pacemakers in the heart. SA node happens to be the fastest of them. That is why it dominates and it paces.
And its rate is, whatever, 90. When it doesn't, it comes down to junction, 70. God has created that as a backup. When that doesn't work, it comes down to Hisian, 45. God created that as a backup. If that doesn't happen, you see the patient in the ER. You are giving CPR, 30. It doesn't give up. Heart is the first organ to start functioning and the last organ to die. It doesn't give up. It goes at 30. It says, I'm still going to allow you to live. That also doesn't happen at 30, then the heart fails. That's why you have these pacemakers coming down, down, down.
Okay, we'll stop this session here. If any of you still want to give us a feedback, one of the students can just keep a few sheets outside. Let them just write their feedback out. Okay, it's good, bad, ugly. Please feel free. Okay, if you have doubts, you can post it on the group for a while, and we'll see what we'll do. How we
have to make way for the next function in this hospital. Thank you.
So, thank you so much. We'll just thank you, Jayashree. See, I'll tell you one thing, all of you. Vote of thanks, Jayashree was supposed to give, okay? I don't know if I'm giving her the opportunity to do that. The team that deserves vote of thanks is the CCT team. Okay? All of them for arranging and all of you for attending. Okay, that's it. That is the crux. You guys attended. Thank you all for making this program a success, and thank you all for arranging it. In addition, we have right from all our other faculty who, I mean, had to leave, and all the faculty sitting behind who've given their precious Sunday to us by not being on duty, but still they are on duty. They've sat through all the talks, and thank you all for excellent talks. Huh? Yeah, of course. So Saikiran and Srinivas, they've sat through the day. Divakar brother is still here. Brother, sorry, I ignored. Yeah, brother Sairam. So Sairam, Dr. Divakar brother is our senior most technician, and he has guided, and Srinivas and Saikiran have guided the students. So Anamika, thank you for comparing. Excellent work, excellent job. Really made us proud. Thank you very much, and I hope you've all gained something. And for everything else, we have to thank the inspiration given by Swami to us. So we'll just have an aarti before we leave. It's hope it's okay with all of you. Thank you.
ओम जय जगदीश हरे स्वामी सत्य साई हरे भक्त जना संरक्षक भक्त जना संरक्षक पति महेश्वरा ओम जय जगदीश हरे शशिवदना श्रीकरा सर्वा प्राणपते स्वामी सर्वा प्राणपते आश्रित कल्पलतिका आश्रित कल्पलतिका आपद बांधवा ओम जय जगदीश हरे मात पिता गुरुदैवमु मरियंतयु नीवे स्वामी मरियंतयु नीवे नाथ ब्रह्म जगन्नाथा नाथ ब्रह्म जगन्नाथा नागेन्द्र शयना ओम जय जगदीश हरे ओंकार रूप तेजस्वी साई महादेवा सत्य साई महादेवा मंगल हारति अंदुको मंगल हारति अंदुको मंदर गिरिधारी ओम जय जगदीश हरे नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा ओम शांति 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 समस्त लोका सुखिनो भवन्तु समस्त लोका सुखिनो भवन्तु समस्त लोका सुखिनो भवन्तु ओम शांति शांति जय बोलो भगवान Just a small announcement before everybody departs for the day. I request everybody, all the students and delegates, to please leave your delegate cards on the reception desk. Reception desk, and sign before you leave so that